Andrew,
Yes.
at what time we gonna need a patient?
In 5 or 10 minutes, whatever. Very soon. Yeah, I'm going to show pretty soon. I just realized I can draw a quick picture.
Okay.
As soon as we're ready. So when we're ready, I'm going to just spend a minute talking about monopolar versus concentric, and then we can bring in a patient and we can start learning together. Do we have a group? Should we start? Yes. Okay. I don't want you to think that there's a big important difference between doing paraspinal mapping with your concentric needles and with our monopolar needles, okay? But there are a couple of subtleties that are worth understanding. We're going to use a concentric needle today. I also forgot my monopolar. I promised to bring one and I didn't. So your concentric needle has the black active on the outside and the reference on the inside, or vice versa, however you plug them in, right? If a motor event occurs near the proximal end, you'll see it because it's right next to the metal. And if it occurs near the distal end, you'll see it because it's right next to the metal. Okay? So all along the shaft of the needle, you can pick up electrical events, motor units and things like this, right? A monopolar electrode is insulated, so if an event occurs in the middle of the shaft, you really won't see it, or you won't see it very well, okay? If the event occurs at the tip, then you're more likely to see it. And so the difference between monopolar and concentric for paraspinal mapping is that when we're in the S specific area, I might see a train of positive waves. It might have come from the mixed area. It might have been out here, not at the tip, okay? We've used concentric needles enough to know that it really doesn't matter too much. But we haven't used them as much as you do. We've done, dozens of cases, not thousands of cases. So you may find out that your mixed column with the concentric needle might have some abnormalities, but it shows up when the tip of your needle is in the specific column. Like I was saying, when I want to do the flexor digitorum profundus, if I use a concentric needle, then no matter where my needle was, if I move this finger or this finger or this finger, it would still make noise, right? With the monopolar, if I'm deep and I move this finger, I get motor units. If I move this finger, I won't see them. I'll be past them, right? Subtle difference, not a really big thing. So we should talk about cases. Who do we have? Should we talk to the first patient then?
Well, the first patient is going to be the Juliana patient.
Okay.
I don't know.
Okay, we'll wait for Juliana to come in. So doing the paraspinal muscles, you want the back muscles to be relaxed, right? So you say, relax, relax. That does not work, right? Be calm and nice and say hello to the patient and, this kind of thing. It's easier to get them relaxed if they're lying on their side and tucked up like a ball, because then they're on stretch back here. But unfortunately, and we've done some studies this way, when a person's lying on their side, your placement of the needle is very inaccurate, okay? So even though it's easier to have them tuck up on their sides and relax the back of their muscles, you start out by having them just lie on their stomach. It's not quite as good in terms of relaxing, but your palpation is much more accurate. So we'll have our patient lie down here. Usually, I have the pillow under their, there we go, under their stomach, especially if they're old and they've got hips that are tight, right? Maybe even a couple of pillows. And in the tables in my office, we have a little hole up here where their face can fit. But you maybe use a towel or something like that. And if they really are contracted, you might even have something like this under their knee so that they're bent over, right? To get them nice and relaxed. I'm going to get this out of the way for the moment. When I have them lie there, I'll usually rest my wrists on their buttocks, okay? And if I'm being very fancy, I'll actually have my elbow on their hamstrings, but this may be too much. If you tell people to relax their back muscles, they tighten them. If you tell them to relax their gluteal muscles, relax your buttocks, then they think about this, not where the needle's going, and they tend to relax better, okay? So I can just get a sense when I'm just resting my hand on their buttocks, I can say, oh, relax that muscle. Oh, you just tightened up again, relax again. And it's one way to get the person relaxed, okay? Another way we'll get the person relaxed is to put one side of the person on stretch. So if they're lying here, instead of being like this, I might have them like this so that this side is more relaxed. So I might push and pull like this. I'm trying to think of what else to say before we get our case. Maybe nothing. You guys coming? Yeah. What other questions from this morning? Any other? There were some good questions.
Do you use gel with anesthetic?
No, I don't. It's not a bad idea. Most of us don't, and I think it's out of being lazy. I think it probably helps with some of the pain, but we don't use it. Have you used it?
No.
No, I think it slows down. You have to wait a few minutes. We also did a study looking at acupuncture to see if acupuncture would make an EMG hurt less. It doesn't help. So poking with a needle does not make poking with a needle hurt less. I use bad jokes. Yeah, I make them relaxed. We talk about things. When you start out, electromyography uses so much of your brain. You're thinking a lot. And when you're a younger student, you're thinking, and the patient thinks you're worried, and they hurt more, right? And now that I'm old, it's just do. Hey. Hello, Andrew Haig. Good to meet you. English only. A seat, please. We need one more chair here.
He does speak English. I will try.
Yeah, one. Спасибо. Yeah, please tell me.
Patient, 65 years old. 6 months ago, it was operation by a total hip arthroplastic at the left side. And he came to us with a pain in the left hip and nothing else. And it was a little bit at the right side. And they made a CT because MRT they can't because he has arthroplastics. Yes, and there was a spinal stenosis at the
an MRI.
It's not CT.
Computer.
Yes.
I'm not listening.
No, you don't want. Okay.
No, I'm joking, because what could she say about an MRI or a CAT scan that would make me pay attention? Cancer, infection, fracture, not spinal stenosis. I'm teaching, but
yes.
Yeah, the radiologist thought that he had symptoms, huh? No. MRIs don't, or CAT scans do not tell us whether somebody has clinical spinal stenosis. It can tell us, it can tell us whether the person is average. Now, do you know why these chairs are this size? They were designed for the average person. Are any of you average? No. In fact, they were designed for the average dead white male criminal in Cleveland, Ohio. Because when the field of ergonomics came out, they measured the bones of a bunch of dead criminals and decided that average was this size. But some of you are women, some of you are tall, some of you are short, And it's the same thing in terms of the radiologist's diagnosis of stenosis. They use statistical deviations from normal as if you all fit in this chair, as if you all should have the same spinal canal. Does anybody know, and I will talk for a bit, okay? And talk, okay. Does anybody, have you heard of Kirkcaldy-Willis's degenerative cascade? William Kirkcaldy-Willis died a couple years ago, but he took a look at x-rays with aging, and he found the normal process that we know, okay? And it goes like this. When you are 15 or 16 years old, your spine looks just like the skeleton that you see in the clinic, you know? When you're about 18 years old or 19, you begin to get annular tears. And mostly those don't hurt, but they might hurt if they happen to be tearing right near where a little nerve is on the edge of the disc. But your MRIs, your CAT scans, your x-rays, your discograms cannot tell if an annular tear hurts or not. So annular tears can relate to pain, but they may not. Over the next years, if you get enough annular tears, you might get a herniation, right? And a herniation, here's a bulging disc, nerve, disc, that's a bulge. That's a herniation. Bulging discs are perfectly normal. They come and go and they have nothing to do with pain. You can follow them over years and you will not see more pain in people with bulges than not. Herniations, you probably know, occur in about 1/3 of people who don't have any pain, right? Herniations are a part of a normal process for our bodies, okay? If the herniation is anterior, it's asymptomatic. If the herniation is superior, it causes a Schmorl's node in the bone, and early before the bone calcifies, that can be a painful event, but then the bone calcifies and it disappears. So when I trained looking at x-rays, they would say Schmorl's nodes are normal, they don't hurt. Well, they do before they calcify, okay? If it herniates posteriorly, it usually doesn't hurt. If you happen to have an immune response to the chemicals in the disc, like phospholipase A2 and other inflammatory chemicals, then you get inflammation of your nerve. A herniated disc does not pinch a nerve. A herniated disc is hot chili pepper sauce. It's inflammation of the nerve. Ow, hot, okay? And that washes away. As you get older, so again, annular tears might hurt, might not hurt. Herniated discs might hurt, might not hurt. As you get older, the disc begins to collapse. The facet joints in the back begin to bear weight. And a joint that's going to bear weight gets bigger. That's good. That's normal. Okay? We get stiffer when we get older. That's normal. You can have pain in those joints when you're older. A young person usually doesn't get pain because those joints aren't weight bearing. A young gymnast would get, or a diver who throws their body might get facet joint pain. But a 20, 25-year-old doesn't get facet joint pain. This is more a problem in people who are in their 40s and 50s. They get mechanical facet joint pain, right? So facet joints can get bigger because of weight bearing, and you can have pain in those joints or not. X-rays, MRIs, and CAT scans do not differentiate between whether a facet joint hurts or it's just normal aging. Okay, the only way to tell is if you inject the anesthetic in the joint and the pain goes away. That's the only way, right? So if you get bigger joints back here, then you have less space in here, right? Bigger facet joint means less space in the spinal canal, so you get a smaller spinal canal, which my radiology friends will call spinal stenosis. It's normal. Some people with stenosis will get symptoms related to stenosis, and it has to do with whether the bones shift or whether the veins get congested. People with congestive heart failure will get stenosis symptoms because the veins are congested, okay? But otherwise, it's perfectly normal. And then if you get to be as old as my grandfather, who died when he was 100 years old, he still was driving his car, but he couldn't move anything. His body completely fused, and he had no pain. So back pain increases towards middle age and actually decreases with old age because our bodies get stiffer. It's not that if you have back pain when you're 50, you're going to have back pain for the rest of your life. On the average, you get stiffer, you have less motion. Is this normal? Does anybody have a pet dog? Maybe a cat? And you have a dog that's 15 years old and it's very stiff and old. But if you have a child that's 15 years old, they can do crazy things, right? Well, what the scientists believe is that as any animal gets older, its brain has a harder time controlling these complex muscles. And if the lion jumps out to eat you, and you're thinking about controlling all those muscles, you're going to become lunch and you won't breed anymore, okay? But if the lion comes out to get you and your spine is just one stiff thing and you can jump away, then maybe you can breed. So every vertebrate animal, as it ages, gets more of what people call degenerative changes in the spine, but they're not a disease, they're a normal finding. You can have pain in those places, but it's not a disease at all, which is why the radiologist calling it stenosis as if it's a disease is really quite wrong. Thank you. Continue. Sorry.
So
Yeah. CT showed some smaller canal than a 20-year-old.
Yes, smaller, and at the L3, 4 and 4, 5. Yes, and we make electromyography, EMG, and nerve conduction studies. Upper and lower limb is normal, but we have low motor unit, at the abductor hallucis, flexor pollicis brevis, and tibialis anterior, and gastrocnemius.
You say flexor pollicis brevis, a hand?
No.
Oh, flexor.
Sorry.
I got okay. So distal. Yeah. It's okay.
We have no H wave. No
Absent.
H wave. Yes, absent. But two sides.
On both sides.
Both sides,
Yeah.
Yes. And I think we make needle EMG, and there was spontaneous activity in the tibialis anterior, more in tibialis anterior, at the gastrocnemius, at the both sides, and a little bit in the vastus medialis. Yes, a little bit.
Yeah.
How about sensory?
We have sensory, but low
amplitude.
Yes, low amplitude. But we think maybe it can be a polyneuropathy.
Right. So the first thing I want to do, of course, is ask my patient what's going on. There's a saying in medicine, and it says, if the doctor shuts up long enough, the patient will tell them what's wrong. So let's ask our friend. And you'll please translate. What are you complaining about?
Что вас беспокоит?
Боли в мышце правой ноге. Не слушается мышцы.
Is a pain in the muscles of the right hip, the right hip, and it's.
Well, это слабость у вас?
Это боли.
Это только боли. Вы говорите, как бы не слушается, слабости в ноге нет.
Есть.
Есть слабость?
Конечно.
Вам тяжело что? Поднимать ее, подниматься по лестнице, встать на носочек на пятку?
Значит, тяжело подниматься по лестнице, встать на носочек практически невозможно. Это правая нога. Вот. Лежа никаких проблем нет. С мышцами.
А левая нога?
На левой ноге у меня эндопротез.
Все, вам тяжело проверить, да?
Эндопротез. Нет, левая нога нормально.
Есть ли нарушение чувствительности где-то? Бегают мурашки, онемение? Нет. Because I didn't see it before. So he just have a pain and he has a weakness. Weakness in the right leg. He can't
stand up on tiptoes. Yeah. What, a key question that I often ask is yes, what can you do right now in this room to make your pain worse? That's a very important question. Would you ask him what he could do right now to make his pain worse?
Что вы сейчас можете сделать, чтобы боль появилась?
Спровоцировать боль. Чем вы спровоцировать ее можете?
Встать, шаг сделать.
Stand up and make step.
And that makes pain, not weak. That makes pain?
И это будет боль в бедре.
Нет, это будет, ну, я не скажу, что боль, слабость мышцы, как после судороги.
Like after
cramp.
Okay, I see.
It will be pain like after cramp.
This one is okay?
Yeah.
Okay.
Yeah, okay. All right. And the other, apologies for being very basic, but sometimes very basic is really smart, okay? The other thing is, I want to reproduce his pain. If I can't reproduce his pain, then I have to think harder, because almost any pain you can reproduce it someplace. I will tell you before I do anything that hurts, so you won't be surprised. I just want to do a simple exam that should not hurt right now.
Он вам будет говорить все, он проведет некоторые исследования и будет вам говорить, если вдруг вам может быть больно при этом.
Некоторые тесты, да.
Тесты,
Я понял.
Yeah. Would you take off your shoes? Yeah, good. And come sit. Yeah. So, okay. This is the best way. My spine exam makes sure that I always overpower the muscles, right? If he's a footballer, he can throw me across the room with the right leg, but maybe he can throw me across 3 rooms with the left leg, and then I've got weakness, right? So I'm always looking at using my body instead of trying to fight him, and you don't have to sit on the floor, but he's not going to move my body, is he? So testing how strong you are, okay? Curl your toes down. Good, good. This side, down. Again, maybe. Toes up. Toes up. Yeah, up hard, and up hard. A little bit weak, yeah. Ankle up. Strong. I can't break it. And ankle up. So you see I'm using his heel in the front. Really working out. Okay. Push forward. Push forward. Good. Good. Pull back. And this is good. That's L5, right? It's pretty strong. Pull back. Squish together. Spread apart. Good. Lift up. Lift up. Scoot back a little bit. Yeah, good. Knees together, ankles apart. Strong. Good. The tensor fasciae lata is a great L5 muscle because it's this close to the spine. It's not sensitive, so maybe the big toe is better for L5. But if the tensor fasciae lata is weak, if you go like that, then I'm really sure it's in the spine, right? So that's kind of a nice test. The other trick is I forgot my hammer one time and I never picked it up again. Because there are some tricks for getting reflexes.
I'll give you.
No. Throw away the hammers. Okay. What do I need, right? When I'm at his ankle, I put my thumb on the dorsiflexors. Because if he tenses up, I'll feel it. And after a while, it becomes unconscious. Where if he's tensing, I go, relax, relax, huh? And if I don't get a reflex, they teach you to do this and all these other things to facilitate a reflex. Be very direct. Simply use the muscle a little bit. So in his case, just push down a little bit. Push down. Too much, just a little. No. Sorry, go back. And now just down a little bit. Too much, just a little. And it's gone. Okay, I will not get an H wave on him. Down a little bit. Good. Okay. Well, just to demonstrate it, there's a patella reflex, and sometimes I'll go like this, if I have to. Okay? Now bring your leg here, right there. Let it stay. He's not showing it. That reflex jumps out more when I've just used the muscle. Do you know the medial hamstring reflex? It's not in most books. It's L5, best reflex. You need to know this one. You grab the medial hamstrings. And again, many people I can just hit and I get it, and I did get it. But if I bring your heel back just a little, it's right there. I'm not sure I get it, I take that back. But it'll kick back a little bit. Okay? So, I'll tell the medical students L4, L5, S1, right? Good way to remember it. So strength is intact, reflexes are absent except we're up at the patella where we can get a decent reflex. Does it hurt if I do this?
Well, remember
I know.
Implant.
It should work just fine though. Does that hurt? Yeah. Is this painful? Okay. Is there any place I can push to make it hurt?
Есть место, где, когда нажимают, больно.
Okay, so now we're pretty sure that this is something that's not coming from the leg, right? Very basic. I think we should go ahead and do paraspinal mapping. You know, you've done some other work on him already, and that'll be kind of helpful. So maybe would you explain to him about what we'll do with the EMG, that we'll put the needle in and we want the muscles relaxed? Okay. So are you ready for a test? Okay, glasses off.
Давайте я вам перестелю здесь эту. I'll change the.
Yeah. Yeah, thank you. Cool. And we have you lie down. Put your nose here. Your tummy here. Yeah. Here, I'll put them way over here. So I don't know how to use your machine. Thank you. This is obviously the ground. Yeah. Can I pull down clothes here? Okay. Yeah. Okay. Good. If people want to, I don't mind if people crowd around, maybe get rid of the chair as long as your camera can still see. And I realized I lost my pen. Does anybody have a pen? Somebody have a pen? Does anybody have a pen? Uh-oh. Oh, maybe I have one in my briefcase. Here we go. This is good. So, okay. I'm just going to make some marks on your back right now. I think. Yeah. Okay, yeah. So, do you know this old joke? A man's under a street light, he's looking for his lost watch, and another man comes and they're both looking for the lost watch, and they're looking and looking, and finally the other man says, well, where did you lose the watch? And the man said, way back in that dark alley. Why are you looking here? Because the light's better. Right? Now, is this a joke you know? Okay. It's easier to palpate the back muscles up here, or the spinous processes up here. Now, I've gotten good at it. I can feel over this fatty area. But if you're not sure, you can find a gap between the bones here maybe. And I feel one maybe there.
Now you are between
the bones. So
between.
There's a spinous process. Huh? Okay. Maybe I feel one here. Now what? If I couldn't feel the next one, where do you think? There. I could just guess. It's probably about there. Huh? It's the same distance, right? And it is. I don't draw all this when I'm doing a clinical case. And then the L5, it's usually pretty small. No, it's not. It's fine. So those, you know, I can start, if you're not good at feeling, you can start up high where there's less fat over the spine and then move down and then ignore that. Now, when I'm pushing, I find the base of the sacrum right there, okay? I can move here, but I get here and it kind of feels stiff. So I think, okay? And now I'm going to find, this is the part I really do map. So over the middle of the sacrum, 2.5 centimeters to the side, over the middle of L5, middle of L4, middle of L3. Those are my 4 spots. That's really what I do mark, okay? I'll do it on the other side because we'll be going over there too. 1, 2, 3, 4, right? So just find the middle of the spinous processes. Those are my 4 places that I'm going to put my needle in from, okay? So let's get our ground and our electrodes all set, if you can help me out with that. So we were joking because back in the United States, I did not use alcohol. Well, I did at the party, but I did. Yes. Let's see. Yeah, it's no good. It's cheap.
No whiskey.
I'll go blind. I'll go blind if I drink this. Alcohol does nothing to decrease infections. Nothing. So I don't use it because it also stings. And if you put it on top of a wound, it's going to hurt. Huh? I don't care if you use alcohol, but you certainly don't have to. I'm doing it because I don't know why today. Just because. Yeah, just for no good reason. There have been studies of, for instance, 20,000 venipunctures to see whether or not alcohol decreased bacteria in the bloodstream. Makes no difference at all. So we have our ground electrode any place? Yeah? Go ahead. please.
Можно вашу ручку, пожалуйста?
Заземлим вас, ручку дайте, заземлим, да.
Yeah.
Сейчас.
Yeah. This is my electrode.
It's on another side.
I got it, I think. Okay. Thank you. Okay. So, let's see. I would typically, in fact, could I have one of the chairs back there? Second chair? Yeah. Okay. So I get comfortable. I find my spot. And I'm typically like this. Again, my wrist is on his buttocks, okay? Relax this muscle. Let it go relaxed.
Расслабьте ягодицу.
And we're going to do some needle pokes in your back.
И вы почувствуете укол иголочкой сейчас.
If anything really bothers you, you can let me know.
Если вам будет очень больно, вы можете сказать, но будет как укольчик, да, в ягодицу, когда делают.
Not yet, not yet. So another trick is, patients need control over the pain, right? So I always tell them, if anything bothers you, let me know. The other thing I do is, right after I poke the needle under the skin, I say, how are you doing? Their immediate social response is, I'm fine. And then their brains begin to think that maybe they're fine, right? So these are just ways to make it hurt less. We're on electrode for, this will be the screen?
What level you want?
Doesn't matter. We're just going to demonstrate. Okay, needle poke. Okay, so there I am. Fat. Muscle. I'm not, can we just get one line across the screen? I'm not used to having 6 lines. I
Одну
can't see.
линию можете сделать на экране?
Yeah, too much noise. Good. Relax this muscle. Cool. Try to make it quiet. Shh. Relax. So,
Не крутите
good.
головой.
Ah,
Прекрасно,
perfect.
вы сейчас чудесно
Cool. So those are motor units, obviously. Insert, get nothing. I'm going to pull my needle out to the surface. Oh, these concentric stick. Now I'm going, so that was the upper part. I'm going to the middle part. I hit bone almost immediately. There's not much muscle there at all. I'm not getting insertional activity that I expect to hear. Going caudally. I'm going to pull out. I just need to see the screen differently. How do we turn off sound here? Okay, yeah. So I'm used to this thing spinning at 10 milliseconds per division. I think you're going very, very slow.
10 milliseconds.
Per division, yeah. So 100, yeah. Okay.
And 100.
Yeah, 100 is good, or 50. Yeah, okay. So maybe I'm not used to your concentric. I didn't really hear a lot of insertional activity there. I'm not sure what to make of that. And maybe I'm not used to your concentrics. So at L4, assuming that I saw nothing there, actually yeah, would somebody grab the marker at L5 on the left-hand side?
На L5 на левой стороне.
All 3 of those, all 6 places have dash.
Минус.
6. Minus. 6. Yeah.
На всех
Up.
3. Ага.
Then I went across.
Там же внизу, опускайтесь, да.
And then I went down. Now we'll go a little bit slower now that we're at L5.
На всякий случай.
Okay,
Поставьте
nice and
на
relaxed.
колено.
Okay, so again I'm at L4 and I'm going up. Here we go. Okay, on. Thank you. Motor units. This is still slow. This screen's funny for me. I'm sorry. I'm not used to it. Yeah, this screen. Try I think it's 10 per division. Spread. There you go. I wonder what that's about.
Maybe
Okay.
50 normal.
Maybe 10 milliseconds.
No, 10 was too slow for me.
20.
I can see this now. Those are all motor units, right? But let's say I found a positive wave right here. What's my first question?
Where are you? Where I am?
No. Did it last a second? If it didn't last a second, I keep going. I keep going. Hit bone. And I pull out. Okay? So that's across the middle and it was normal. Now I'm going down. So it's going to be the bottom of that L4. I find a positive wave. It lasts a second. What do? Watch my hand. I go back. I look again. I go back. I look again. I didn't find it. We keep going. I can't read the screen. I'm sorry. But when I've got the needle out of him. Weird. Okay, stop. I'm just, because this is very, are you used to looking at the screen like this?
No, I use 10 millimeters.
I wonder if he has it 100. Yeah. See, he says 10, but it's very slow. That's not correct. Try 1.
1 minute.
Yeah. Let's see what that looks like, because it's moving way too slow for me to try to see if there's fibrillations. All I can see is the mode units. Oh, you continue to drink. Are you okay? Okay? Good. Good. So I'm not very helpful in making a real diagnosis because I'm just not able to appreciate fibs. So I'm up to, so at L4, sorry, minus 6, yeah? Yeah. Okay. Going up to L3. That looks better. And can we have it not raster, just once across and that's all? Because it covers itself up.
1 millisecond.
Is this
Like this?
No. Just one on the screen. That's just, no, that's not screwed. Go back to 10. I'm so sorry.
10.
Maybe 5? 5, try 5. Go to 5. You got 7.5. Okay, yeah, other way. I see. Yeah, good. We'll see. And 6 of those, can we just get 1? Is there a way? Not 2, no raster. So sorry.
А тут не получится.
Here you can have only 6.
I want 0 or just 1. Just 1.
I understand.
Okay.
What I
All right. Okay. I will live. Okay.
Wait, maybe.
Пуха нарезал, меньше.
Yeah.
Вон они вверху. Да. Только вторую, да.
Уменьшение.
Он работает на Николете, как у меня. У нас вообще одна линия. Поэтому мы тоже не понимаем. Я тут сижу, сейчас для меня это...
Yeah. I'm sorry. I just know that I'm not reading things well.
It's okay.
Yeah. Okay.
Отлично, ему больше не надо.
Так это уменьшаемый пухлый анализ.
Да.
Секунду вы хотите, да? Вот секунду.
А сколько там помещается, кстати?
It's good enough. That's okay. That's okay. All right. So I'm up at L3. Now I don't know why I'm going up first instead of down first. It doesn't matter. I know I just have to get to all these. Okay. And we're in. Now that one pop looked like a fibrillation, but it wasn't. It didn't. Oh, now that did not last a second. Whatever I saw there. So it doesn't count. I'm going to come out. I'm going to go straight across the middle. That's motor units, isn't it? That's not fibs. That's distant motor units.
And they sound like
the pattern, right? So let's say I found a train of positive waves there, and it lasted a second, and I reproduced it. That's 1 plus. But where am I? Well, I don't know, but if I insert, well, now I guess I'm near the end of my needle, so I'm probably at the midline, but I hit bone within a centimeter, so I get a 1 plus in the S or specific column, okay? Oh, sorry. Move out. Relax muscles. Relax here. Good. Relax. Good. So, and this screen is not good for looking, but
We will make the change on the second patient. Don't worry, we will put the one.
Because they're overlapping enough, so I can't show you anything either. Let's pull out, okay, and turn. How do we turn this off when I? Oh, you do it over there. Okay, good. Let's see. What can I teach on this one? I don't know if you pay attention to the speed at which I'm doing this. Does anybody know the units when you say I have increased insertional activity? Huh? You've heard increase. What are the units? What number do you use to reflect that if you were a scientist?
More than 300.
Yes.
Opinion, and the second opinion more than 500.
Yes.
I use 300.
Good. I mean, this is what many people don't know that. I've always been impressed you know this stuff. Right. So you're looking at how many times, how far it goes on the screen, right? When I'm inserting, I just make little discrete stabs, and I think you all know you have to stop suddenly, right? You can't go, you have to go chick, chick, right? Right? And my insertions, maybe I try to do 5 millimeter insertions. I'm not measuring, but that's kind of the idea. So that I get a number of insertions on the way down in, okay? And then I come back out and do the next level. Let's see, scoring. Let's do this fourth level and I'll pretend like we've got something. Are we ready? Okay.
Расслабьтесь, пожалуйста, еще с этой стороны.
Mode. Oh, perfect. Thank you. All mode units, huh? Now, if you're following the scientific rules for paraspinal mapping, if you see more than 2 mode units on the screen, then you've got too many mode units. You put a 0 because you have unreliable data. Okay, but that we can find our way through this. So here I am. Let's pretend like that's positive waves, and I'm still in the mixed column, and I insert some more, and I find a different set of positive waves. Oh, that's automatically 2+. I keep going, and I'm sure I'm in the mixed column because now I hit bone, but I'm quite a ways in. And by the way, I'm really not seeing anything now that we're looking here. So it's my rhythm. Okay, good. Done on that side. You are okay?
So we don't have spontaneous activity here.
I'm not so sure down here, but no, I did not really see any. I don't know if you guys did.
No.
Okay, yeah. Maybe on the other side, I will just do it at my usual pace because I worry that you spend too much time thinking and worrying about this. It's really kind of quick. So I'm going to do 1 or 2 levels at my usual pace. Okay? Mm-hmm. Over here now. Ready? Go. Boom. Okay. On. I paid attention to that, but that was a motor unit. Hit bone. Is that a fib?
It could be.
Yeah, okay, let's lasted a second. Okay, I'm going to try to repeat. I backed up. Didn't find it. Back up. Didn't find it, so it doesn't count. Even if it was a fib, it doesn't count. Okay, there's 1 level. I'm going to just do 1 more level and I'll slow down. I'm finding a little bit lateral. My ultrasound probe, my needle, motor units, told me that I was too far from midline. That I was too far away from midline, right? I bumped into, I'll do the math, I'll show you this on the drawing. But so I moved closer to midline here. What do you think? Motor units, sputtering, huh? It's not. Okay, you are doing well. Good job. Good, okay. We can turn that off. So you can see that, what did that take me? Maybe a minute to do those 2, and I was still stopping for you guys a little bit. It goes really quickly in a normal subject, okay? When they have findings, you have to record. But if they have lots of findings and they're all over, even the accuracy of calling it 2+ versus abnormal and it's diffuse. So unless you're doing a research project, you don't have to be exactly right with the score. Once you have a high score and it's diffuse or a high score and it's focal, the difference between 10 and 12 is not much. You get to rest, okay? Let me just show something up here. Okay, good. Okay. Yeah. I'm trapped. Okay, thank you. What? I'm just going to draw one more. Yes.
One more time?
One more time in just a moment.
Okay.
Okay. Just a quick note. Let's see. So, really simple mathematics. There's the surface of the skin. There's the midline. You need 2.5 centimeters. And if you're going at a 45-degree angle, you get to 2.5 centimeters deep. Whoops, 2.5 deep, okay? So a squared plus b squared is equal to c squared. So does anybody have a cell phone? Could you do 2.5 squared plus 2.5 squared? What do we get? Yes, yes. High school. What do we get? The square root of this squared plus this squared. No, I don't. 2.5 squared plus 2.5 squared square root.
И корень квадратный.
Yeah. Everybody's busy.
3.5? Can you know?
Maybe. More. It's like 40 something. I thought.
3.5 is a bit.
Корень 12,5.
3,5.
А не 27. Там же
It's longer than that.
13,5.
This.
Сложить 3,5.
So the point I'm trying to make, though, these are all people with a doctoral degree, and they're doing high school mathematics, and I can't help because I'm messing it up too. It's okay. My point is that you need a 50 millimeter needle, okay, at a minimum. You can't do this with a shorter needle. In people that are maybe this size or a little bit bigger, you're going at a steeper angle. You're at 60 degrees. And you need an even longer needle. So in my office, for the back, I have some 50 millimeter needles, and I have some 75 millimeter needles. Big, long needles, because you have to get down that far if you have to get past a little bit of fat, adipose, and you have to get at a steeper angle. So it's very common to do these. Again, when we did our cadaver studies, it is impossible for those needles at these angles to penetrate the spinal canal. You're not going to get in the spinal canal with those needles. It seems very deep. The first times I did it, I was very afraid. But we did cadaver studies, and you're not going to get the needle in the spinal canal. So that was just a little sidebar there.
We need longer.
50 or 75, yeah. Maybe in him.
To penetrate the canal.
Yeah.
Even more.
Big, long. So in this man, my 50 millimeter needle is maybe not getting as much muscle as I would like. I wish I had a little bit longer needle. Okay, it's okay. I can move closer to the midline and cheat a little bit. But he could use a 75 millimeter needle. I'll do the top two locations. We're not seeing anything here though, even regardless. So why don't I do those? Or actually, would somebody like to try and do one of the levels? I'd rather have somebody else do this. Somebody, go, please, grab some gloves.
With you.
You do. I'll watch. Okay.
Just don't tell about this. So
Yeah. Okay.
Here.
Right.
Yes.
I know. Okay.
Thank
Yeah. But I'm going to step up here and let me grab my seat here.
She's his doctor.
Yeah.
So.
That's right. I got. Okay. A little bit more. Okay. It's okay. So when people are doing this, when I'm teaching, I usually stop them, be prepared. I may stop you to try to make teaching points or to observe what you're doing with the technique, just because otherwise I just don't know about alcohol in Ukraine. I'm having fun with this. This is good. Okay. Yeah. Nice and relaxed and yeah.
Расслабьтесь.
Mm-hmm. Mm-hmm. Now, just for a moment, let go of the needle. Leave it right there. Just let go.
Let go.
Yeah, let go.
Okay.
Okay. Now, completely move your hand away from the needle. So I want to show everybody. You see, people will often make a mistake of putting it in the skin at 45. She's doing it just perfectly well, okay? But people will often put it in the skin at 45 and then they'll bend the needle as if it would bend under the skin, okay? If I've got a needle going through the skin like this and I bend it, it's not going to do this. It's going to just bend and stay in that position. So if you're not sure about palpation, you let go of the needle and you see, and this one is perfectly 45 to 60 degrees. But maybe on the next one I'll show what I mean. So letting go of the needle to see where you really are aiming is a good idea sometimes. Go ahead.
Можно переключить.
Ой, а мы не слышим.
Да, там вы переключите сейчас.
Вы не сможете ничего слышать.
Okay, yes, good. Then we're right on. Yeah? Typically a 50 millimeter needle hits the bone at about 48 millimeters.
Меняйте. Еще раз.
Yeah.
It's look, it's like positive waves. Again,
I didn't see. Okay.
Try again. She
Yeah. So you try it 2 times.
More than 1 second.
Now-
even, and twice.
Yeah. Okay. And where are you? Are you close to the midline, within a centimeter of midline?
Yes, I'm good.
And you're going. Are you going straight across or going up?
I'm going
Straight.
straight.
Okay. So you're at L3. Let me come back. I'll be the score guy. At L3, in the middle. So she was here and she found 1 train of positive waves that she could reproduce twice. That's a score that she got, huh? Okay. Continue.
Она оттолкнулась от нее, да. No, нет, сейчас он нет. It's not now. You see, it's.
I didn't think it was, but we pretend.
Тут уже последний у нас осталось.
Нажмите все.
Больше, чем 2 сантиметра.
Все?
Да.
Можно?
Да, нажимайте. Сейчас, да.
Есть, да?
Bone? Yes. Okay, good. Sorry, this is for me.
How about the angle? Angle.
Yes. 45.
No. I just want you to do.
Yeah, you can't quite see here. If he lets go, then I know. Yeah, let go. Let go. Got it. Okay, a little steep. It's good. It's good. But you see, it's maybe 60 degrees. That's good. 60 is okay. 45 is good. Yeah. Okay.
Лишь бы не 90, как он говорит.
But I suspect you will not hit bone because I think it's a little bit lateral. Just looking. No bone. A little bit lateral. You would take the needle in to about here, take it out, pull it out completely, completely out. Yeah. No, completely out. All the way out. Yeah, they can.
Полностью.
All the way out. Yeah, good. Okay. And steep 60. Yeah, that looks better.
Все последнее. Все расслабьтесь.
Yeah. Remember this question. I want to make sure I answer when we're done here because that's another great question. Okay.
Sure.
Okay.
So the conclusion, we
My
did not
conclusion is-
find.
Yeah, you found things distally. You did not find things in the paraspinals.
Yes.
So this is not radiculopathy.
Uh-huh.
I think that's true. Yeah. Our friend is done. If he wants to be done, he can get up.
Все. Все, вы можете вставать.
He's hooked up on the way. Thank you. Thank you. Yeah, you. Very good. Thank you. Everybody, I think we should help.